Well, hello and welcome. It is indeed my honor to share with you our experience at Duke Health in using artificial intelligence to maximize value in clinical care. And we've been able to do that by focusing on different elements of the life cycle of artificial intelligence. For those of you who may not know us, we are an academic medical system based in the beautiful state of North Carolina. We have 3 hospitals consisting of 1,500 beds. We keep ourselves very busy. In any given year, we would have on the order of 76,000 inpatient admissions, and we will see 3.6 million outpatient visits every year. And our annual revenue is north of $4 billion a year. I don't think you need to tell you that there's a lot of excitement with artificial intelligence these days. But from the real world in clinical care, I would like to suggest that making AI work in real life setting is sometimes like pushing a square peg through a round hole. And I'd like to share with you a story from Duke Health to illustrate some of the challenges. So I'd like to take you back to about 3 years ago in the summer when our chair of surgery reached out to the CIO, my boss, and he wanted our CIO to help him integrate a third-party surgical complication risk prediction platform into our electronic health record, which is a product we have purchased from Epic. He intended for this to go get widely deployed throughout the surgical services. He reassured us that funding was approved, and with that request came a statement of work written by the vendor that calls for us to complete the integration within 4 months. So with that, we went to work. I asked my surgical informaticist, who is also a practicing physician assistant in the surgical services, to jump in to help. And the framework that he used was the 5 rights of decision support. For those of you who may not be familiar with this framework, we have learned over the last few decades in using computers to guide decision-making at the bedside that in order for decision support to work well, not only do you have to provide the right information, but you need to do it by delivering the information to the right recipient through the right channels, in the right format, and at the right points in the workflow. So with that framework in mind, our surgical informaticists first asked the vendor, how would they like to display the risk scores to the clinician? The vendor very confidently told us that they have developed a really nice user interface that displays no fewer than 14 post-operative complication risks or probabilities. And all they really wanted us to do was to build a button within our electronic health record so that our busy clinicians in the perioperative setting, so this includes surgeons, anesthesiologists, and nurses in the preoperative, intraoperative, and postoperative setting, to find this button on the user interface in the electronic health record and pop up this new widget and use one of those 14 scores to make different clinical decisions. Needless to say, we were a little skeptical about the chances of success for this particular approach. We then asked the vendor, how would they like the clinicians to react to the scores? And they literally had no idea. So our surgical informaticists sat down with them together with some clinicians. And it turns out that of the 14 scores that they calculate using the predictive models, only 3 of them could lead to meaningful clinical actions. For example, one of them predicted the risk of the patient being readmitted back to the hospital after being discharged after the surgical procedure. And they were thinking that perhaps that score could be shown to the case managers to plan for more aggressive follow-up after discharge. Another risk score predicted the risk of the surgical wound coming apart after the operation, something we call the wound dehiscence. And in those cases, the surgeons may choose to use a vacuum pump to keep the wound sealed after the operation. So we next asked our vendors to show us the list of variables they would like us to feed into the models. And as we were looking through the list, we observed that they wanted a number of variables that were typically collected in the preoperative, i.e. before the surgical operation, and some collected during the operation and some afterwards. And then they told us that their model was actually built using data typically abstracted by trained chart reviewers, mostly nurses, who would review the chart after the patient has been discharged in order to get high quality, reliable data. And this is how they abstracted the predictors and whether the patient actually had those postoperative complications. And then we asked them, have they thought about whether the data that is actually collected in real time, entered by our busy clinicians, may or may not have the quality that they have come to expect. And this was literally the first introduction to the issue of data quality. In addition, remember, one of the use cases was going to rely on the model to predict the risk of wound dehiscence. And in those cases, the surgeons would want to get the vacuum pump set up as the patient rolls into the operating room. And we noticed that for that prediction model, they were going to use a number of variables, both collected before the operation and during the operation. And we told them that they really can't do that because they can't really use the future to predict the future. Cheating is not allowed in predictive models. So with these concerns in mind, and to their credit, the vendor did agree to slow down and work with our informatics team to make sure that the variables are adequately mapped and that the data quality would be reasonable. And we also brought to the table some researchers to help them design some studies to understand the value of the prediction models. And then we also worked with the clinicians to really think about what kind of user interface would make sense to them, and more importantly, what kind of decisions would actually they would like to make based on those risk prediction models. So I think this story really illustrates how, in order to do prediction model well in the clinical setting, you really need to bring to the table a lot of different perspectives and disciplines. You need clinicians to help you understand the mind flow and the state of mind of the clinicians and how that could be influenced by prediction models and the guidance. You really need researchers to help you think about your study design in order to understand the impact. And then you need folks who are skilled at designing interventions on the computer user interface. And those typically are folks with some training in human factors and clinical decision support design. And then you need to bring to the table IT professionals who can clean the data and feed the variables into the model. And we really made it a point to do this well, because we really were very worried that as much excitement as there is with predictive modeling, we were worried that if we don't do it well and our clinicians start ignoring it, then even if we were to be able to recover with this model and with future predictive models, they're going to just lose faith and keep ignoring them. And at the end of the day, we want to make sure that these predictive models do no harm because we have an ethical obligation to protect our patient. And in this process, we talked a lot with our colleagues around the country, and we figured out that these were challenges that were not unique to Duke. In fact, everybody around the country was managing the hype around predictive models and trying to figure out how to make them work in the clinical setting. And of course, the Food and Drug Administration is expressing a strong interest with these prediction models. In 2019, the FDA issued a set of draft guidance to help both the developers and implementers of predictive models in the clinical setting to decide whether the FDA might actually exercise oversight responsibilities for these prediction models and treat them as formal medical devices. And of course, if the FDA were to treat them as medical devices, the bar for approval goes a lot higher. And then throughout the country, there were a lot of academic leaders who were really strongly advocating for better stewardship of artificial intelligence and machine learning. So in order to make sure that we would do this right at Duke, we actually talked to a lot of experts around the country, and we learned quite a few things that really resonated with us. One of the first things we confirmed was that making predictive model work is hard. As I alluded to, the village of people that really need to come together to make it work. As one of our informants told us, more of the work is actually going to be focused on the intervention and the program to support the intervention in a sustainable way. The technical and analytics pieces are getting easier and easier. And of course, there was also a lot of challenges in separating the hype from reality. And in response to that particular lesson learned from the field, we really took it very seriously to make sure that with all predictive modeling projects, we don't really just think about the predictive modeling itself, but we really think end to end. Specifically, we bring together the clinicians together with the data scientists so that they can work together to define the goals of the project and what success will look like. Then we ask our IT folks to come together to help us clean the data and feed it into the predictive models, some of which need to be developed internally, but some of them may be available off the shelf from vendors. And then the insights from these predictive models need to be presented in a digestible format to influence decision-making at the bedside. And time again, what we find with projects with or without predictive model is that you can put a shiny toy in front of clinicians and they may pay attention to it for a few days, but making sure that they use it consistently to make decisions and to improve care month after month, it is difficult to sustain. So the implementation and sustainability plan together in the context of change management is something that we always focus on. And as I was alluding to, clinicians are busy and they all have different workflows as they take care of different patients. And one of the things we have really harped on with all predictive modeling projects is to really think about the workflow. So this is an eye chart, and I don't expect anybody to read the details, but this is a flow chart that illustrates how our case managers in the population health management office would use the risk stratification model to identify patients at the highest risk of being admitted to the hospital or being sent to the emergency room. And the yellow boxes you see are the places where we expect our case managers to use the prediction model to triage the patients and decide which one they would reach out to first. Another challenge that we have learned from our colleagues around the country is that as well educated as our clinical colleagues are, they may not be very familiar with this concept of predictive models. And many of the metrics like area under the curve or calibration plots are metrics that they are not very familiar with in their clinical training. And forget prediction models. Every clinician has seen their fair share of guidelines and calculators that have come and gone in clinical practice as the state of medical science advances. And many of these prediction models that are developed using data collected in one or maybe a few healthcare centers generally don't have the gravitas compared to, for example, guidelines that have been widely adopted and embraced by professional societies. And to make matters worse, many of the high-performing models that are very good at predicting the future based on data are black box models. I'm thinking about many of the neural network models. And even when these models appear to be very good at predicting the future, it's really hard to put a finger on why, and clinicians are naturally a little suspicious. And just in case you think this is just a problem localized to Duke or some of the experts institutions that we talked with, there was a study that came out not even 2 months ago where some of our colleagues in the University of Michigan looked at the sepsis prediction model that Epic, our EHR company, has put out. We don't use that model, but we've heard quite a bit about it. There was a lot of enthusiasm about that model, and I remember distinctly that the CEO of Epic telling everybody at the annual user group meeting to just use that model and turn it on. Well, there's nothing wrong with the model itself. It was developed with data from a number of their clients, but when the researchers in Michigan looked at the performance of those models in other institutions, it really wasn't that good at predicting sepsis. And in some ways, it's not that surprising because we know that a model developed using one data set probably needs to be fine-tuned and recalibrated in another one. But this is an important lesson learned for the field in that I think the hype of prediction models, it may not be fully justified. And in the very least, we need to think about how to deploy them and use them well. And of course, one of the key challenges with predicting the future is how you can change it. We have quite a few, for example, models that predict mortality, death. And unless you have a way of telling the Grim Reaper to stay away from our patients, there's no guarantee that these mortality models would actually make a difference. So in the domain of readmissions prediction, one of our informants told us that they too found that these readmission models, while they had face validity and they seem to be identifying patients at high risk of being readmitted, it is not always clear what you can do to intervene to change the trajectory of the future. And of course, as more and more organizations implement many predictive models, the computer is telling our clinicians to pay attention to different things, and many clinicians have developed alert fatigue and trying to make sure that what we show them is of value and that they trust is something that I think many are grappling with. And of course, like all software, predictive models, AI, and machine learning require care and feeding. And for example, many of these models need to be recalibrated. And if you happen to use a model that was developed internally and the people who developed them initially move on to other jobs, for example, in Silicon Valley being hired away by Facebook or Google, then who is really going to pick up the pieces and do the recalibration when you know that that should be done? And of course, making sure that these predictive models that are being used 24/7 by our clinicians are reliable and don't malfunction when there is a software upgrade or changes in workflow. That takes an army to make sure that these work right. So with these challenges in mind, we at Duke have developed a framework to make sure that we deploy predictive models that will make a difference and that we deploy them in the right way. And the framework that we've used is actually one that we have borrowed from the FDA. So as you can imagine, if a pharmaceutical company is developing a compound and they think that this may be of benefit to patients, they would go ahead and do a number of clinical trials, first looking at toxicity, and then they would try it out in small numbers on patients to see whether there may be a suggestion that the compound might be helpful. And if so, they might move on to some large-scale randomized controlled trial. And if the data is promising, the pharmaceutical company will take the data to the FDA and get approval. We think that predictive models should really undergo that level of scrutiny. At the model development stage, we want to make sure that the data scientists work together with clinicians to make sure that there is that cross-fertilization. And when they think that they have developed a model that could be used in the bedside, we don't just turn it on and expose them to the clinician. We actually ask them to go through what we call a silent evaluation so that they can turn on the model and feed into it real-time clinical data to make sure that the models is performing before you show the output to the clinicians. And they really need to think through all the issues of workflow, and actionability. And when they have figured out all those issues, we actually will let them undergo a clinical effectiveness evaluation. And during this evaluation, we don't just look at how well the model predicts the future. We want to see whether the models actually would influence clinical decision-making and make a positive impact on clinical outcomes. And if the results of that evaluation is successful, we would ask them to continue to use the model and make sure and perhaps scale it up for other areas in the health system. And we want to make sure that these models, once they are in maintenance mode, are actually being monitored. And throughout each of these phases, we want them to undergo certain checkpoints that are represented by the green diamonds. We call them G0, G1, G2, and GM. And in order to oversee this process, we have pulled together a committee called the Algorithm-Based Clinical Decision Support Oversight Committee. And what I've shown on this slide is the composition of that committee. And as you can see here, we have a number of constituents. We bring together clinical and data science leaders. And we've also brought to the table staff in the health system that represent the regulatory perspective. So we bring to the table lawyers who understand the issues regarding intellectual property and FDA regulations. And then we also bring to the table expertise with evaluation, mostly from the clinical research space and the biostatistics space. And then we also ask members of our informatics and technology, information technology teams to come to make sure that the predictive modeling teams are designing the right implementation. And then once they are done, they monitor the behavior of the models in a responsible way. Now, this committee has been busy over the last 6 to 9 months. We've learned a lot, and we continue to learn things every week. But one of the first things that we've had to grapple with is the scope of what we want to manage. And we have actually discovered that there's quite a bit of complexity. The focus of the ABCDS Oversight Committee are on these data-derived predictive models. But oftentimes, these can get blurred with models that are actually derived from clinical consensus, and sometimes clinicians may develop some rules of thumb that add points together, and they may look very similar to many of the regression models that you see in AI and machine learning. And then that's both those two categories are different from implementation of guidelines that have been well accepted by professional societies, which we call standard of care. And in order to tell the three categories apart, we actually have adopted the posture of asking proposals of new decision support to register so that we have some basic information to perform the triage. And we focus our evaluation efforts on the highest risk clinical decision support, namely the ones that are developed using data either at Duke or elsewhere. And just to give you a snapshot of where we've been busy. We have no fewer than 18 models that are currently, as of July, in production that are being monitored. We have 9 that are going through different phases of evaluation to make sure that we understand whether they work technically and whether they are improving clinical care. And there's a healthy pipeline that we at least know about that will be coming our way and that we can offer guidance for to make sure that that they stand the best chance of impacting patient care in a positive way. So there's still quite a few things that we need to do. First of all, we will need to focus in the next few months on how we monitor models and developing the technical requirements and the technologies needed for that. And we need to start making sure that we consider the issues of bias in model development. And then as the FDA continue to hone the guidance around what constitutes as a medical device when it comes to machine learning algorithm-based clinical decision support, we will need to align ourselves with the thinking from the federal government. But some of the things that we have learned along the way that I'd like to share with you and highlight is that in the domain of machine learning and artificial intelligence, predictions do not always translate to better clinical outcomes. And because we are talking about real patients and the well-being, we really need to make sure that these models do no harm. And the evolving regulatory and legal standards are calling us to make sure that we validate and evaluate these models before they're put into clinical use. And machine learning and AI, like all software, do have the life cycle and require a certain amount of ongoing care and feeding, and that really needs to be considered upfront. And as organizations implement more and more of these models, a standardized intake and oversight approach so that you understand where they are in their life cycle and that they can be managed in a coherent way probably is something I would strongly recommend to all healthcare organizations. So with that, I would like to close. My hope is that by sharing our experience with everybody, that we have more machine learning models that are being used, put to good use, just like pegs that can find their holes in the puzzle so that we can actually push the envelope together with machine learning and artificial intelligence in healthcare. Thank you very much.